Hello students, welcome to the third video lecture for healthcare ethics. So this is week 12 of our course and we are approaching the end. Everyone should have received a scanned copy of your midterm exam and your worksheet from last week from me via email. If you have not received this is a problem. So if you are watching this video right now and you haven't received this email with your worksheet or your midterm exam, stop, pause the video, open your email, and send me an email. And all it has to say is, "Help, Kim, I didn't get my midterm back. I didn't get my worksheet." Okay? So do that now, and then come back and listen to the lecture. If you've already got your midterm and your worksheet, then you're good to go. So this lecture covers two readings, the first of which we've already spoken about. So it covers the New York State Department of Health Task Force on Life and the Law Ventilator Allocation Guidelines, written in 2015. And you guys read some excerpts that were posted on Blackboard. The lecture also covers Arthur Caplan's recent article, "Getting Ready to Confront the Unthinkable." I'm not going to be talking too much about Caplan's article, but I'm asking you to read it as an example of an op-ed essay. So we're going to be writing op-ed essays in this course, and the reason you're reading this is to give you some preparation. We'll be reading another op-ed essay next week. Your worksheet this week asks you to do a bit of close reading, analyzing Caplan's essay, and I'm going to trust that you guys can do that on your own. The worksheet for this week also asks you to find another example of an op-ed essay in preparation for the writing assignment. So when you're reading Caplan's essay, don't just think about the content. Think about the tone. Think about the writing. Think about how it is different from the articles we've read so far in this course. So how is it different from Cetron and Landworth's article that we read for last week? Or even Foucault's chapter that we read for last week? Who is the intended audience of this article? So Caplan is writing for a public audience rather than an audience of students or scholars, like most of the authors that we have read thus far in this course. And so what I'm asking you to do when you read the text is think about how that looks on the page. What's different about writing for a public audience? So you guys are going to need to know this because you're going to be doing it. So the OpEd assignment, which is the next writing assignment for this course, the sort of major assignment that was on the syllabus from the beginning, it's currently up on Blackboard. I'm asking you to please take a look. And the worksheet for this week encourages you to start thinking about it as well. You will be submitting a pitch for your OpEd assignment on May 1st, so as part of next week's worksheet. So not worksheet 12, but worksheet 13. And the op-ed itself is due on May 15th. But that stuff's up to you, more or less. And what we're going to talk about, what I'm going to focus on in this lecture, is the New York State Department of Health Ventilator Allocation Guidelines. So the first thing I want to note for you guys is this reference in the very beginning of the text to the 1918 influenza pandemic. Perhaps you've heard a fair bit about the 1918 influenza pandemic now. It's a really useful point of comparison. It is the most recent major epidemic of the scale of the epidemic we are currently experiencing in sort of global memory. And a lot of people are bringing it up as an example for comparison to coronavirus. And it's used in the NYS DOH ventilator allocation guidelines as an example of a pandemic that reaches a scale that would require ventilator allocation rules, such as they propose. But it's worth noting, just for the sake of scientific accuracy, that COVID-19 is not an influenza virus, okay? I'm sure you guys know this, but it is a coronavirus, and coronaviruses are a different family of viruses than influenza viruses. Okay, so that said, and I encourage you to look up historical information about the 1918 influenza pandemic, but it's not going to be the focus of our lecture today. So the ventilator allocation guidelines were prepared by the New York State Task Force on Life and Law and the Department of Health in November of 2015, and they are a publicly available document. So you can go and download the whole thing from the New York State Department of Health website if you choose. And in fact, that's part of the strategy of this document, is to make transparent such guidelines in advance of an epidemic of the sort we are experiencing now. So it's freely available, publicly available, anyone can download it. But it's also 272 pages long. So it's really, really long and not so easy to read. So I tried to excerpt it for you guys. What I gave you to read was selections from the executive summary, which appears at the beginning of the document, and an excerpt from the adult guidelines in chapter 1. You also had a paragraph from the pediatric protocol, all the way at the end of the text, that's on the subject of the interface between pediatric and adult patients. And I gave you that in part because there's a question about it in your worksheet. But I hope it was clear when you guys were looking at the PDF that you do not need to read the parts that are marked off with X's. So I tried to do that to sort of limit the amount of reading that you guys had to accomplish for today, because I know it's a lot, and I know the prose is rather difficult and dense in this. It's very sort of legalistic. And that's also a difference from the articles we've been reading thus far in this course. Okay, so then thinking back to last week's readings, this document, the New York State Department of Health Ventilator Allocation Guidelines, is a contemporary example of a disaster preparedness plan. So this is a 21st century version of the 17th century documents that Foucault was looking at. So you might ask yourselves while you're reading it, how is it different? How is it the same? So in both cases, I think, there is an attempt to contain disease with writing. In 17th century France, it was statistics, keeping track of who is alive and who is dead, rates of infection, movements of people, etc. In this case, it's an attempt to contain all of the messy variables of clinical decision-making with a rational procedure, with scales and systems and order. And that's what all of these complicated color codes and steps and rules and scales and measurement systems that they provide are about. It's about attempting to contain the really difficult ethical decisions of ventilator allocation within a systemic structure, one that is governed by law and ethics and writing. So this is also a document of the sort that Cetron and Landworth were calling for in last week's readings. So it is a disaster preparedness plan that pays, quote, careful attention to the ethical values at stake in public health decision-making. So that's the quote from the very end of the Cetron and Landworth article. Ethical values, they think, deserve to be a major part of planning for public health disasters. And the ventilator rationing guidelines explicitly name their ethical values. They're very clear that they too participate in this idea of planning that is grounded in biomedical ethics. And they actually make an argument, the authors of this text that we're reading for this week, that is really similar to the one Cetron and Landworth make. And they argue for including more ethical values in planning for a pandemic. Basically, what this argument amounts to is that the public, in their understanding, will be more likely to accept difficult decisions, such as ventilator rationing, if the decisions are perceived to be just, if they are grounded in a just framework. So this brings us back to the question of justice, the sort of major biomedical ethics principle of justice that we've studied already in this course, which was the occasion of us first introducing this document in our class discussion before we went digital. So you guys even had a question about this on the exam, which most of you got right. And so I'll read the question out for you. The New York State Department of Health ventilator allocation guidelines for severe influenza pandemics prioritize patients for whom ventilator therapy would most likely be life-saving. Which of the material principles of justice described by Rogers and Brannock-Meyer would this allocation strategy fall under, and why? So which of the material principles of justice from that justice reading we did a couple weeks ago would the guidelines from the NYS DOH fall under? The correct answer here was capacity to benefit. So the guidelines prioritize people who are most likely to benefit from the access to a ventilator. And you can see this. So now is a good time to open your text. If you look under section 4, so that's Roman numeral 4, very clearly stated, the guidelines' primary goal is saving the most lives. So that's the header in that section, which is, it's on page 4 of the document itself. So if you look at the bottom, there are page numbers that are part of the document that are different from the page numbers on the PDF. On page 4, so the guidelines' primary goal is saving the most lives. This aligns with the capacity to benefit as a strategy for distributive justice. So we've talked about justice as one of the key principles of healthcare ethics, and now we're talking about how it's applied in the situation of a pandemic. So what are the procedures? What are the rules and regulations necessary to ensure that justice? So I'm going to read for you the section that is under the heading, The Guidelines' Primary Goal, Saving the Most Lives, on page 4. The primary goal of the guidelines is to save the most lives in an influenza pandemic where there are a limited number of available ventilators. To accomplish this goal, patients for whom ventilator therapy would most likely be life-saving are prioritized. That means they are the ones who are most likely to get a ventilator. The guidelines define survival by examining a patient's short-term likelihood of surviving the acute medical episode and not by focusing on whether the patient may survive a given illness or disease in the long term. Patients with the highest probability of mortality without medical intervention, along with patients with the smallest probability of mortality with medical intervention, have the lowest level of access to ventilator therapy. So let me read that one for you again, because the language kind of ties itself in knots. So patients with the highest probability of mortality without medical intervention, so those who are most likely to die, even if they don't get medical intervention, and patients with the smallest probability of mortality with medical intervention, that is, those who are most likely to survive anyways without medical help, those two groups have the lowest level of access to ventilator therapy. Thus, patients who are most likely to survive without the ventilator, together with patients who will most likely survive with ventilator therapy, increase the overall number of survivors. So the trick here is figuring out who's likely to die anyways and who's likely to survive without a ventilator, so you can figure out who should get the ventilators, thereby increasing the total number of survivors. So note the definition of survival here. A patient's short-term likelihood of surviving the acute medical episode. There's a more detailed definition of survival given later in the document, which specifies that quality of life is not to be taken into consideration. So it's just, are you going to survive now? And are you going to survive at all, in any way, any capacity? So this is in contrast to the concerns we had discussed earlier in the semester regarding end-of-life care, where quality of life is often a consideration and an important one. But the authors here argue that quality of life and other, quote, subjective determinations of long-term survival, end quote, that these things introduce bias. So they write on page 34, triage decision makers should not be influenced by subjective determinations of long-term survival. Note subjective there, as opposed to the objective criteria that they are interested in establishing. Triage decision makers should not be influenced by subjective determinations of long-term survival, which may include biased personal values or quality of life opinions. So the end goal here is simply to increase the overall numbers of survivors, as they say explicitly, and to do so without bias. So that means without sexism, without racism or homophobia, without classism, without ableism, so without discrimination against disabled people, without religious discrimination, but simply on the grounds of bare life. However much we might doubt the ability of these guidelines to ensure these fundamental principles of human equality in practical situations of determining access to care, this is the central question that they ask. Who is the most likely to survive? How can public health officials ensure the greatest number of possible survivors? Okay, so then, if we take them at their word, how does it work? How are the ventilators allocated to ensure the greatest possibility of survival? How do the hospitals decide who gets a ventilator and who doesn't? It's not based on who can pay for it or who is the most beautiful, who is the most, who fits into our society's categories of priority the best. According to this text, it's based solely on clinical decision-making factors. So what they give us after this is a bunch of sort of steps, 3 steps and 4 colors. And I'm going to walk you guys through them, and then we're going to sort of spill them out a little bit and then connect them together. So how does this work? Step 1 is the application of exclusion criteria. So the first thing that occurs when determining if a patient should have access to a ventilator is the application of exclusion criteria. The basic question here is the patient going to die soon anyways from unrelated medical conditions? If so, they don't get a ventilator. The examples they give of this are actually pretty extreme. So it's cardiac arrest and burns over more than 90% of the body. So are you having a heart attack right now? Okay, you don't get a ventilator. It seems like the number of people who fall into the exclusion criteria category would actually be very small. Step 2 is the assessment of mortality risk. This is the key question. This is the sort of where the central decision making takes place. So this is where the guidelines ask, is this patient likely to survive? Will this patient benefit from ventilator therapy? And this is where the sorting into color codes occurs, and it's the primary determination based on the color codes of who has access to a ventilator and who does not. Step 3 occurs once the patient is on the ventilator. And the question here in step 3 is, are you getting better? So they implement periodic clinical assessments or time trials, and these assessments result in reassigning the color codes. Okay, so what are these color codes? I'll read them to you in the order they list them, though maybe it's not the sort of clearest, but we're going to go for it because it's what they've got in the text. So I'm going to start with blue. So blue is exclusion criteria, and it refers, so people who fall into that first category, are you having a heart attack right now? Then you're blue. Or do you have burns over more than 90% of your body? If you have any of the exclusion criteria that fall on this list, if you're likely to die soon anyways, that makes you blue. But it's also people who are assessed in step 2 of the clinical assessment who are understood to have the highest mortality. So patients who are most likely to die even with ventilator therapy. Patients who might need a ventilator, whose condition might indicate a ventilator would be useful, but who are likely to die anyways. So people, in the case of the influenza pandemic, who will likely die of influenza, but also people who might need a ventilator for other reasons. So they don't discriminate based on the nature of the disease, only on the need to access. So blue, patients who are likely to die anyways. Red is for patients with moderate risk of mortality. So these are the patients who are most likely to recover with the ventilator and not likely to recover without it. The red patients are the priority category. They are the ones who have the highest access. So they are people whose condition indicates that they need a ventilator and that they might die, that they're strongly likely to die without access to a ventilator. Yellow patients are patients of uncertain mortality, so they have intermediate access. These are patients who are very sick, but don't clearly fall into the red or blue categories, and their likelihood of survival is intermediate or uncertain. So they may or may not survive even if they get the ventilator. So they have a lower priority than the red patients. And green patients, and green is for go, green patients have the lowest risk of mortality and they don't get access to ventilators at all because they don't need them. These are the patients who are going to survive without ventilators or are being weaned off ventilators. They were in one of the other categories. Now they've improved, they've gotten better, they can go home. Okay, so green patients are good to go. Yellow patients are unclear, much like a stoplight. And red patients are the ones that have the highest access and they have the greatest risk of dying without ventilators. And blue patients, those are the ones who, I think perhaps the most difficult decision, but those are the ones who are very, very sick and are likely to die anyways, even if they do get access to a ventilator. Okay, so red patients get the ventilators first, then yellow, then blue. If there are more ventilators than patients, if there isn't a shortage, then everyone gets ventilators. If there are more patients than ventilators, so if there is a shortage, red and yellow patients get ventilators and blue patients might not. If there are even more patients, only red patients get ventilators and blue and yellow patients do not. So red patients get priority and then yellow patients and then blue ones. So an important caveat here is that the guidelines do not permit comparison within the color codes. So patients are not competing against each other. So that means a red patient who is slightly sicker is not given higher priority than a red patient who is slightly less sick. And in the situation when there are more red patients than ventilators, access is randomized. The one important exception here, and it's why I had you guys read that extra paragraph at the end, is the question of youth. So if there are children and adults who are classified as red patients, and there are more of these red children and adults than there are ventilators, then the children get priority. So the important thing to note here, though, and you'll need this for your worksheet, is that this does not apply in the other direction. So while youth is considered as a factor, old age is not. A 30-year-old red patient and an 80-year-old red patient have the same level of access to ventilator therapy. But a 40-year-old red patient and a 12-year-old red patient do not. The 12-year-old gets priority in a situation of immense scarcity. Okay, so let's review. Blue patients are those who are most likely to die even with ventilator therapy. Red patients are those who are most likely to recover with ventilator therapy and not likely to recover without it. Yellow patients may or may not survive with ventilator therapy, and green patients don't need it. Okay, so how does that bring us back to the steps? So the first step is the application of exclusion criteria. Are you going to die right now from something else? Okay, you get classed as blue, you don't get a ventilator, you're not on the list. Step 2, assessment of mortality risk. That is the sorting of the patients and an initial triage decision into these color codes. And then step 3 is the periodic clinical assessments or time trials. So the question here is, once you are on the vent, are you getting better? And these assessments result in the reassigning of those same color codes. So I'm going to read to you guys from page 6. In step 3, official clinical assessments at 48 and 120 hours after ventilation therapy has begun are conducted to determine whether a patient continues with this treatment. In order for a patient to continue with ventilator therapy, she or he must demonstrate an overall improvement of health status at each official clinical assessment. After the 120-hour assessment, patients are evaluated every 48 hours with the same clinical framework used in the previous time trial assessments. So you get evaluated at 48 hours Once the patient is on the ventilator, the patient gets evaluated at 48 hours, at 120 hours, and then again every 48 hours. And what happens at each of these assessments is they reassign the color codes. So if you are getting better and you are still really sick, you still need a ventilator, then you stay, and you were on a ventilator and say you were a red patient, then you stay in the red color code. And then if you get much better, you move to the green color code and you get weaned off the ventilator. But if you get sicker, if you get much sicker and it looks like you are likely to die anyways, then you get put in the blue color category. So the purpose of the time trials is to allow for extubation, for removing patients from ventilators, and to do so in an ethical manner that relies on clinical data and works towards the goal of increasing access to care. So that means, in practice, these guidelines prioritize patients who get better quickly. Patients can be extubated either because they got better, so they moved into the green category, or because they got worse, they moved into the blue or yellow categories. Or even patients who are already doing rather poorly, not likely to survive, are in the blue or yellow categories. And in this situation, there is someone else who is waiting, who is in the red category. That is, someone else who is likely to get better with ventilator therapy. In that situation, the patient might be extubated as well. So let me walk you guys through that one again, because that one seems the most counterintuitive ethically. In a situation where a patient is doing quite poorly to begin with, but at the time when the first color codes were assigned, there were enough ventilators that a blue patient or a yellow patient got a ventilator in the first place. But then there's a new patient who shows up who is likely to die without access to a ventilator and is likely to survive with access to a ventilator, so a red patient, then they get priority. So the patients who are most likely to die get extubated in favor of the patients who are likely to survive. So think about that from an ethical perspective. How is utilitarianism at work here? So if you guys look on page 33, we get a definition of triage, which is the sort of central principle that they are using here in order to determine their decision making, with some modifications. And the definition they give sounds a lot like utilitarianism. So if we were actually in the classroom right now, I would ask you guys to give me the definition of utilitarianism here, because we have talked about it already. And I would wait awkwardly while you thought about it. But since we're not in the classroom, I will give it to you. In fact, we can refer to the definition that is given in the text. So if you guys look on page 33, the guidelines say, hold on, I'm going to open it and read it from the text. The guidelines say that the goal of triage is to do the greatest good for the greatest number of people. So doing the greatest good for the greatest number of people is a standard principle of utilitarianism. It's a standard definition of utilitarianism. And this, in fact, sounds a lot like where we started with this lecture. So the guidelines' primary goal was to save the most lives during a pandemic. But think back to the trolley problem here, where we agreed that it was better to kill one person in the trolley track version to save the 5 other people stranded on the other track. But we had that emergency room version of it where we all agreed that it was morally wrong for a healthcare provider to kill a homeless person to save the lives of 5 other patients who needed organ transplants desperately. So it's wrong to kill a homeless person and harvest their organs, we all agree, but it's a form of utilitarianism. And so utilitarianism doesn't always look that good. And so what you guys might want to think about is, how does utilitarianism work here, in this context, as a material principle of justice? And why? Why do we think utilitarianism might work in the situation of ventilator rationing? I think Caplan's article can help you with this. So it might be a good place to turn there in your reading, but it's a question for you guys to consider. So the last thing that we're going to do in this lecture is I'm going to just run over the ethical framework for allocating ventilators, which occurs on page 35. And a lot of these look like terms that we have considered before. And it refers to the author's investment in grounding this document in ethical principles, as I talked about at the beginning of this lecture. So grounding this set of guidelines in medical ethics. So if you guys look on page 35, there's a helpful little box where they list the 5 principles that they are operating under. The first is a duty to care, and they define that in the paragraphs that follow as related to the question of physician abandonment. So, an ethical allocation scheme must respect the fundamental obligation of healthcare providers to care for patients. This looks a lot like beneficence to us. Physicians must not abandon, this is a bit later in the paragraph, physicians must not abandon, and patients should not fear abandonment in a just system of allocation. So tying this principle of beneficence through the duty to care to justice. Patients who do not receive ventilators and are still under their physician's care obtain alternate forms of medical intervention and/or palliative care. I wanted to draw your attention to this because it also appears in your worksheet, and it's a term that came up in your last set of worksheets when I asked you guys to supply me with terms. So, everyone who is not on a ventilator gets alternate forms of medical intervention and/or palliative care. So if you flip back to page 8, alternate forms of medical intervention, such as other methods of oxygen delivery and pharmacological antivirals, should be provided to those who are not eligible to receive ventilator therapy or those who are waiting for a ventilator. In addition, actively providing palliative care, especially to patients who do not or no longer qualify for ventilator therapy, decreases patient discomfort and fulfills the provider's duty to care, even when the clinician can no longer offer ventilator therapy. So, why do patients who are not granted access to ventilators get palliative care? This returns us to our key principles: beneficence, as we were just discussing, and non-maleficence. So, as I just read for you guys, palliative care decreases patient discomfort and fulfills the provider's duty to care. Okay, so from duty to care, we move on to duty to steward resources. The authors point out that healthcare providers have a duty to steward resources even in ordinary times, and it just means being careful about distributing things that there might not be an endless supply of. So the obligation they refer to, the obligation for government and healthcare providers to responsibly manage resources during a period of true scarcity. Which seems pretty straightforward. There is a responsibility to manage resources ethically during a period of true scarcity. If you look a little bit lower down in the paragraph, this is tied to the difficulty that we saw last week in terms of public health of balancing the individual against the group. So providers need to balance the obligation to save the greatest possible number of lives against that of the obligation to care for a single patient. So the duty to steward resources helps strike that balance. Okay, the third one is duty to plan. The duty to plan is the responsibility of healthcare systems, not individuals. So it is the responsibility of hospitals and governments and states to prepare documents such as this one. An absence of a plan, they write, an absence of a plan leaves allocation decisions to exhausted, overtaxed, frontline healthcare providers who already bear a disproportionate burden in an emergency. So it is the ethical responsibility of institutions to plan for such a crisis before it exists. You might note here some of the reflections they include on systemic injustice. So they write in the next paragraph that the task force acknowledges that current access to healthcare is unequal. And so even though they're trying to be as equal as possible, as equitable as possible, they write, no allocation system for a crisis can resolve iniquities in pre-existing health status resulting from unequal access. So you guys might think if the duty to plan might actually extend to a duty to resolve unequal access before it occurs, before a pandemic occurs. Unequal access is occurring all the time. Okay, so the third principle is the one we've been talking about all along, distributive justice. So a just system of allocation must be applied consistently and broadly to be fair to all. So you have to have a set of principles like the ones we outlined, and they must be applied consistently. All patients in the same color category must get the same treatment. If some red patients got ventilators and some red patients did not, even in a situation where there were plenty of ventilators, it would look thoroughly unjust. And so one of the useful things they point out here, and there was sort of more detailed information on it earlier in the document, is the question of resource allocation, resource distribution between facilities. So a just and equitable healthcare system cannot allow for more expansive access at a prestigious private facility and more restrictive access at a community or public hospital. So I remember you guys bringing up this point when we discussed this in class a couple weeks ago when we were actually in class in person and we were talking about distributive justice. So their solution here is to apply a statewide mandate and rely on the state government to distribute supplies in advance of such a situation. Whether or not this works is hard to say, but it is the ideal of this document, is to prevent a more prestigious private facility from having more ventilators to distribute than a community or public hospital. Ethically sound responses, they write, ethically sound responses to a public health emergency must not exacerbate disparities in access to care. Rather, planners must designate appropriate resources for the most vulnerable, whom are most likely to suffer the greatest impact. So there is a responsibility of the state to care for its most vulnerable citizens. So the third point they raise is transparency. And that's the point they accomplish by putting this 272-page document online and hoping that someone will read it. So any just plan for allocating ventilators requires robust efforts to promote transparency, seeking broad input in design of the plan, and educating the public. And the reason they do this, it's the same reason we discussed last week, is that communication is important in a situation of a pandemic, and without it, guidelines such as these might fail to win public support. And when you are dealing with a public health emergency, you need the public. Otherwise, it won't work. Okay, so I think we discussed most of the key points in this article. I know the system of color codes and trials is confusing and is maybe not our responsibility to know, but it's a really useful real-world test case for the principle of distributive justice. So as you guys are doing your worksheet, and especially the third step on the worksheet where you're looking for other op-ed articles, think about how the principles of healthcare ethics that we have learned thus far in this course are related to contemporary healthcare problems, and specifically, in this case, the question of ventilator allocation in the state of a pandemic. Okay, so that's it. I'll look forward to receiving your worksheets on Friday, and I will return your worksheet from this past week then. Okay, take care.